Welcome to ICU Nephrology at KidneyCon. I'll be very brief with the introductions to maximize the time for the speakers. And we have four great talks today with four great speakers. And we're going to start off with Michael Connor from Emory University. And he's going to talk about mean arterial pressure versus abdominal perfusion pressure in the ICU. Welcome, Michael.
Hello. Thank you so much. Let me get my screen shared. Thanks again for the invitation and the opportunity to participate in this great conference again. Let me just get my screen shared here. And all right, I assume that my slides are coming through. Is that correct?
Yep.
Perfect. All right. Well, again, thank you so much for the opportunity to join this again. I was asked to speak about mean arterial pressure versus abdominal perfusion pressure. What matters more in the ICU? I am an intensivist and a nephrologist at Emory. I was thinking about how pre-pandemic, we were at KidneyCon several years ago, and I was able to enjoy these wonderful sculptures in downtown Little Rock. My kids had a fun time playing on some of the slides and park at this downtown park. And we enjoyed having a conference at the Clinton Presidential Library. So I hope that soon the pandemic will end and we will be able to all join together again at in-person conferences because obviously having the camaraderie of being together is so much better than this virtual. But for now, this is what we've got, and I'll try to teach you something over the course of the next few minutes, and then happy to take some questions. By way of disclosures, I have some prior research collaborations. I have no pertinent conflicts of interest that pertain to this lecture, and my wife is also Emory faculty and also has no conflicts associated with this. So the real goal here, the real question is, how do we prevent organ failure, or AKI, and how do we promote organ recovery? And what should we really be focusing on in the ICU? And I think that we really should discuss abdominal perfusion pressure as just one form of perfusion pressure, and that's what we'll discuss as we go through this talk. So let's start out with a question for everybody. Obviously, we're not going to be able to poll people here, but just if you can think in your own mind, what is the best target? What is the best goal map in critical illness? Do you want to be a map of greater than 60, greater than 65, greater than 70, greater than 75, or greater than 80? Obviously, there's I probably fall into the category of I don't know a lot, but think about this question as we move forward, as we go through this talk. I also think it's really important that whenever we give talks, that we try to leave you with some of the take-home points of the talk, and to do that early in case you may lose focus as we go. I want you to make sure that you at least have some of the take-home points that we're going to discuss. So the take-home point number one is that pressure doesn't equal flow. So that's take-home point number one. And the second take-home point is that the goal in the ICU is organ perfusion. That's how we're going to foster patient recovery. So let's also talk about some very basic definitions. Obviously, blood pressure, we know what that is, but it's a measure of the pressure that the blood is exerting against the vessel wall. And we typically measure this as arterial pressure, but we all know that we also have venous pressure, like a central venous pressure, and there's also capillary pressure as well. And then the other sort of pressure flow relationship that we have to define and remember, and nephrologists know this well, but that it's really pressure change that determines fluid flow. So flow occurs from a pressure of high pressure to an area of low pressure. And the larger this difference, the higher the flow. And so if the P high goes up, then you can have more flow. Or if P low goes down, then you can have more flow. But if P low goes up, then you're going to have lower gradient and less potential flow. And so perfusion pressure is the flow perfusion pressure is the concept of how do we determine what the actual flow is in the organs. And a flow then is a function of both the inflow, the compartment, and the drainage pressures. And so if you do that this way, your perfusion pressure then is your P inflow minus the sum of your compartment and your drainage pressures. So let's first talk about blood pressure. We're going to spend the first sort of third or half of this talk talking about blood pressure. So what's the history of blood pressure? So William Harvey in the late 1500s, early 1600s sort of described circulation of blood. He was the first to describe that. Then Stephen Hales in the 1700s was the first known measurement of blood pressure. And he did this by basically taking a horse and inserting a large glass tube into the jugular artery, and then measuring how high the pressure came up, or how high the column of blood came up. And then in the late 1800s, the sphygmomanometer was invented, and then Nikolai Korotkov also improved the technique and described the various Korotkov sounds and sort of systolic and diastolic pressure. So how did we arrive at blood pressure being sort of the primacy of everything? You know, it's an easy thing to measure. We can measure it invasively and non-invasively, and it's basically an easy concept to think about, which is that blood pressure is the product of cardiac output and systemic vascular resistance. And mean arterial blood pressure then is your cardiac output times systemic vascular resistance, in other words, your blood pressure, plus your CVP, and that's sort of the function of how you get mean arterial pressure. So if we then sort of solve for this and look at the different ways that mean arterial pressure is actually calculated or estimated, we can estimate MAP. Many of you remember from medical school that you can estimate MAP by taking 2/3 of your diastolic pressure and adding it to 1/3 of your systolic pressure. So that's your estimated MAP. You can also basically do diastolic blood pressure plus 1/3 of your pulse pressure, or the difference between your systolic and diastolic pressure. For people who have a heart rate of greater than 60, you can also calculate it in a much more complicated way, which is to take your diastolic blood pressure times this factor, which is obviously not something I can do on rounds in my head, and then multiply that by your pulse pressure. And then it's important to know that modern telemetry monitors that use arterial lines, they actually do not use these calculations. So the telemetry monitors, when you have an arterial line in, they're calculating MAP by integrating the area under the curve of the arterial pressure waveform and dividing that by the duration of the cardiac cycle. So what are the MAP targets in critical illness, and why do we sort of come up with the sort of guidelines, and where do the guidelines sort of come from, where people sort of say a MAP of 65 or 70? So first of all, we know that autoregulation of flow and pressure within the organs falters when mean arterial pressure goes down. This occurs in the kidney, the brain, and other organs as well. So historically, sepsis guidelines recommended a MAP of greater than 60 to 65. And these were largely based on small studies in the early 90s, largely a total of less than like 500 patients. It was a mix of retrospective and prospective studies. But in summary, the increased MAP did not necessarily yield an improved survival or organ function. And subsequent to this, in the late 2000 and early 2010s, there was another randomized controlled trial that was done in septic shock. And it took 400 patients and randomized them to a low MAP versus high MAP target. And you can see that they achieved very good separation in the blood pressures between these two groups. So these groups were really actually quite different. But what did they show? That there was really no difference in survival in the cohort at large. However, However, there was subgroup analyses that suggested, for example, people with chronic hypertension did better and had lower AKI rates if they were in the high MAP target group than the low MAP target group. And this is not the end of the story. There was another larger, albeit retrospective study of many thousands of patients like basically 9,000 patients with septic shock, and that they sort of qualify them based on what their blood pressure ranges were throughout the time that they were requiring pressors, and that they showed very clearly that more time spent with a MAP of less than 65 increased the risk of AKI in patients. So the time-weighted average here, you can see, if I can get my pointer back up, the time-weighted average of MAP, as well as the predicted marginal probability of acute kidney injury. So as the time below MAP 65 goes up, then as you spend more time less than 65, you have more risk of AKI, and as well as myocardial injury as well. And the same thing occurred with a MAP of less than 65. More time spent with a MAP of less than 65 increased your risk of mortality. So in this study, MAP of 65, which was sort of used as the cutoff, seemed to be sort of appropriate in terms of what they were, that maybe the MAP of 65 is correct. But it's not really the whole story. So if you look further into this trial, they show that as your MAP thresholds increase, your risk of mortality continues to go down, even at these higher blood pressures. So if a higher MAP is not beneficial, then we should have leveled off here at a MAP of 65, and we didn't. The risk of AKI goes down and the risk of MI goes down. So there still is this question about what exactly is the right blood pressure for these patients. So if we then turn and say, well, what's the relationship between blood pressure and blood flow? Let's dive into this physiology a little bit. So under normal circumstances, when your heart is beating, you get both a pressure wave and a flow wave. So every time the heart beats, you're feeling your pulse, but you're also gonna get a wave of blood. And how are those things related? The pressure wave travels much faster, about 20 times faster than the flow wave does. And so as a result of this, the pulse precedes the stroke volume by several seconds. And so when you're feeling the pulse in the radial artery, you're feeling the pressure wave, but the flow is going to follow behind that by several seconds. What about when the heart is sick? So when the heart is sick and you get increased resistance and impedance from vasoconstriction, for example, then the speed of the pressure wave will increase, but the speed of the flow wave will actually decrease. And then in the setting of like sepsis, where you get vasodilation and decreased resistance to flow, then the speed and magnitude of the pressure wave will decrease, while the speed and volume of the flow wave will actually increase. And so when you, in critical illness, have abnormal vascular resistance and impedance, arterial pressure is no longer a particularly reliable index then of blood flow. So in summary, pressure does not equal flow. So if pressure doesn't equal flow, then how can we estimate blood flow and organ perfusion? And if pressure doesn't equal flow, then blood pressure alone is probably not really the goal that we should be shooting for when we're trying to resuscitate and deal with our patients in the ICU. And the goal, as I told you before, really needs to be understanding blood flow and organ perfusion. So let's go back to this pressure-flow relationship. And I described these things to you before about the flow and the perfusion pressures being also driven by compartment and drainage pressures. So What is flow? Flow is the volume and rate of fluid in a pipe or a vessel. And blood flow in cardiac is so much like blood pressure, blood flow is also determined by cardiac output and systemic vascular resistance. Cardiac output, as we all know, is determined by preload volume. It's determined by stroke volume, and stroke volume is obviously dependent on left ventricular end diastolic volume, as well as contractility of the heart. And then heart rate obviously impacts cardiac output as well. Stroke volume is also determined by afterload, which is systemic vascular resistance, and afterload is obviously largely determined by arterial constriction and dilation. But systemic vascular resistance is also determined by compartmental pressures and venous capacitance and venous pressures. So let's focus on these two issues now as we move forward through the rest of this talk. So first, talking about venous pressure and venous capacitance. So what is normal venous pressure? I think that we are mistaken sometimes when we believe or we have taught people that the CVP is supposed to be sort of 8 to 12. Under normal circumstances, venous pressure is quite low. The pressure at the end of the capillaries in most capillary beds is around 12 to 18 millimeters of mercury. Right atrial pressure is anywhere from around -2 to +4, depends on the position of the patient and what portion of the spontaneous respiratory cycle or positive pressure ventilation that the patient is in. And central venous pressure is quite variable. Again, depends on the site of measurement and the position of the subject. So for example, if you are standing up and you measure the IJ SVC CVP, it's going to be in the -2 to 0 range or +2. If you measure the IVC pressure or the femoral venous pressure when you're standing up, then you have a whole column of blood that has weight to it that gravity is pulling down, and so the pressure will be higher in that circumstance. We also know that fluid accumulation leads to venous congestion and venous hypertension. And so if the capillary pressure is not very high, and normally blood drainage out of an organ or a capillary bed depends on the pressure difference from the capillary to the venous pressure, if venous pressure increases, then your pressure difference on the venous end of the capillary to the veins goes down, and it impairs capillary drainage, leading to organ interstitial edema and organ failure. So increased venous pressure is sort of like venous afterload. It's the afterload that the venous circulation is contributing to capillary drainage. And so as that goes up, you get decreased venous drainage, decreased organ drainage, and decreased organ function. So a lot of people ask me then, is this really true? Does this really happen? So let me give you a couple of stark examples. Can anybody tell me what's going on? Well, you won't be able to tell me, but think in your mind, what's going on here in this leg? This patient's leg is all purple right now. Does anybody know what this is? This is called phlegmasia, phlegmasia curulidolians. And this occurs from venous obstruction to the blood flow in the leg. And so as a result of an acute venous occlusion of the limb's central vein, you get an inability to drain blood out of here, and you develop a compartment syndrome and arterial ischemia, as well as then progressing to critical limb ischemia, muscle and skin necrosis, and limb loss. And you can see here that this patient had to have fasciotomies and drainage of this in order to sort of save this leg. So acute venous hypertension can cause limb ischemia. Acute venous hypertension can have impairment in drainage of your visceral organs, for example. So imagine this happening if you have really high CVP and your kidney can't drain, and suddenly your kidney is looking like this. So the effect of venous congestion and volume overload is really quite plentiful. You get all sorts of organs that become dysfunctional as you get venous hypertension and venous congestion. So let's narrow in on the kidney and talk about how this occurs in the kidney. So as you get venous hypertension here, you then start getting venous congestion, tubular leakage, or interstitial edema of the kidney. And this raises the pressure inside the kidney because remember, the kidney is encapsulated and therefore it can't really expand that greatly. And as a result, you get increased pressure within the nephrons because you're getting compression of the nephrons, and that leads to an increased pressure in Bowman space. And as a result, you can no longer filter at the level of the glomerulus, and you get a reduced ultrafiltration gradient and reduced GFR at the glomerulus. This leads to oliguria, concentrated urine with a high specific gravity, a bland urine sediment, and if you care to check these sorts of things, a low FeNA fractional excretion of urea. And so really, this is a very intense perfusion-mediated pre-renal acute kidney injury. The problem is that this very frequently gets misinterpreted as total body fluid overload, but intravascular volume depletion. And people are saying, well, they're pre-renal, they must be total body fluid overloaded, intravascular volume depletion. That's why they look pre-renal. Let's give them some more fluid. But in reality, the problem here is venous hypertension that's causing this issue. And just to show you, in this mouse model of sepsis and intra-abdominal hypertension, which I know that we're going to talk about intra-abdominal hypertension in a second, but in this mouse model of cirrhosis and controlled patients, they increased the intra-abdominal pressures. And as they increased the pressures in both cirrhotic mouses and control mouses, BUN and creatinine both went up because renal function was getting worse. And more importantly, what they showed here was that they got progressive compression of the renal tubules and interstitial edema. In other words, this was a venous hypertension model for AKI. And so it really does happen that as you get venous hypertension, you get compression of these renal tubules, interstitial edema, and an impairment in GFR. So in summary for this section, venous hypertension and venous congestion decreases organ perfusion. Let's talk about compartmental pressures and how they affect organ perfusion pressures. And by these, we talk about abdominal perfusion pressure, cerebral perfusion pressure, coronary perfusion pressure, and mean perfusion pressure. So let's first talk about intra-abdominal pressure. So intra-abdominal pressure is the steady state pressure within the abdominal cavity. Your organs, your any sort of space occupying fluid or lesions contribute to this. Abdominal wall compliance issues contribute to this. And normal is quite low. And in critically ill patients who are on the ventilator and have gotten fluid, it can go up a little bit. What are the definitions? Intra-abdominal hypertension is a sustained or pathologic elevation in intra-abdominal pressure of greater than 12. Abdominal compartment syndrome is an intra-abdominal pressure greater than 20 when paired in the presence of new end organ dysfunction. And you can have both primary abdominal compartment syndrome and secondary non-traumatic abdominal compartment syndrome. What about abdominal perfusion pressure? Well, that's MAP minus your intra-abdominal pressure, and the goal is around greater than 60. We know that intra-abdominal pressures that are even only slightly elevated when paired with sepsis and hypotension can cause organ perfusion problems, because if MAP is low and intra-abdominal pressure is mildly high, then abdominal perfusion pressure can fall greater than 60. And we know that intra-abdominal hypertension is consistently associated with higher ICU mortality, and an inability to maintain abdominal perfusion pressure strongly predicts mortality. But is this really common? Yes, it is. In all of these prospective incident studies in ICUs of all sorts of different flavors, intra-abdominal hypertension affects anywhere from 30 to 80% of patients, and abdominal compartment syndrome is also quite common within the ICU. What are the risk factors? Why is this so common? It's common because everything we do in the ICU contributes to an increase in intra-abdominal pressure for the most part. You can have decreased abdominal wall compliance and respiratory failure and elevated intrathoracic pressure. So high PEEP and being on the ventilator is going to make the abdominal wall not move very well. Abdominal wall edema, increased intraluminal contents, ileus, obstruction, gastroparesis, and then increased abdominal contents like ascites, liver dysfunction, pneumoperitoneum, or hemoperitoneum. Capillary leak, polytransfusion, and brisk fluid resuscitation all contribute to elevations in intra-abdominal pressures and abdominal compartment syndrome. So basically, you can see why half the patients in the ICU have intra-abdominal hypertension, because everything we do in the ICU, it puts the patient at risk to having increased intra-abdominal pressures. And there's a strong linear correlation between volume status and intra-abdominal pressures. So as you expand water fluid, intra-abdominal pressures go up. And what do? We resuscitate patients with a lot of volume. And a raised intra-abdominal pressure can have a wide-ranging impacts. It can impact the gut, leading to increased translocation of bacteria and sort of SIRS. You affect your heart, you affect your lungs, and you strongly affect your kidneys, having oliguria, decreased GFR, proteinuria, diuretic resistance. Does this sound like any of your patients that you have in the ICU? So, and it really does hold true. In these animal models, they increase the intra-abdominal pressures. And as they increased intra-abdominal pressure, renal blood flow fell very rapidly, as did GFR. And as they defleeted the intra-abdominal pressure, then blood flow returned. And you can see here that renal vascular resistance goes up greatly in this animal model. In another animal model, they showed that as you get increased intra-abdominal pressures from the sham to group 1 to group 2, you'll see that all sorts of other signs of inflammation are also increasing quite significantly. So, and in humans, definitively, abdominal compartment syndrome is a cause of acute kidney injury. And intra-abdominal hypertension, short of compartment syndrome, especially in the setting of shock, is also strongly associated with progressive AKI in multiple studies. What about perfusion pressures in other organs? So cerebral perfusion pressure is MAP minus ICP, or MAP minus jugular venous pressure. The cited goal is greater than 60 or 70, but the data is pretty contradictory as to whether or not this is the proper goal for patients. We do know from CPR research that coronary perfusion pressure is very important. And if you aren't able to maintain a coronary perfusion pressure of greater than 15, then you basically do not achieve ROSC during CPR. And then there's a concept called mean perfusion pressure, which is your MAP minus your CVP, and that flow to organs must factor in the venous pressure as we discussed. And fluid resuscitation leads to increased CVP, and we already sort of discussed how deadly that can be. There was a couple of articles that have shown that low mean perfusion pressures increase your risk of acute kidney injury. So for each 1 point increase in mean perfusion pressure above 60, the progression to AKI stage 3 decreased by 4.5%. Another study showed that if you characterize the mean perfusion pressure deficit, so how long did the patients have a mean perfusion pressure deficit of greater than 20%, from normal, and in the increased time that you have a low mean perfusion pressure increases your risk of advanced AKI. So we don't have yet, though, a lot of prospective studies looking in the ICU about whether or not we should be targeting, for example, mean perfusion pressure as opposed to just mean arterial pressure or flow. So in conclusion, pressure doesn't equal flow. We need to focus on organ perfusion, not blood pressure. Blood pressure should not be used alone to reassure the provider that flow and perfusion are adequate. We should use multiple different data streams that help us understand blood flow and perfusion. These things are like urine output, mental status, skin temperature, lactate clearance, SCVO2, intra-abdominal pressure, mean perfusion pressures, abdominal perfusion pressures. And that optimal cardiac output can be difficult to define, and desired cardiac output in a given patient can change over time. So just looking at cardiac output by itself and measuring it may not be appropriate either. We should individualize the hemodynamic targets. We should be checking things like intra-abdominal pressure, and we should have a low threshold for inotrope support. Just because someone has a good ejection fraction doesn't mean that they necessarily have adequate cardiac output. And I do think that when you're in the emergency department or the very first few hours of taking care of somebody with sepsis, pressure of 65 or 70 may be a reasonable initial target during resuscitation, but that we should view this pressure cautiously during the maintenance phase of critical illness. So when they're on day 1, 2, or 3 oppressors, we should view that cautiously. But more research is needed, and hopefully we can collaborate together. I know I'm running up against my 30-minute time. I hope there may be a time or two for questions. I'm going to have to come back to the ICU, so I won't necessarily be able to stay around much longer.